alternate routes of fluid therapy.
In keeping with the title of this meeting, controversial areas of surgery, I guess one of the ways to create some discussion would be to challenge some of the time-honored methods of doing things routinely. We began these studies at Ohio State because of some of the complications that we're all aware of intravenous fluids, mainly those of the house staff who didn't want to start IVs every morning and pull them out at 3 o'clock in the afternoon and let the patients up and around. They left them in all night, and we had some problems. And on certain elective surgical procedures, which we'll discuss, we carried out some studies which gave us a little indication of how fluids administered by other routes, namely peritoneal fluids and intestinal fluids, might be handled.
Surgical hemostasis.
There are a few events in clinical medicine which are so ominous as the failure of hemostasis. And for us as surgeons, there are a few failures in basic physiology which are so catastrophic.
The thoracic outlet syndrome.
The thoracic outlet syndrome has been, I think, one of the confusing syndromes to me over the years. Confusing in diagnosis, in indications for surgical therapy, what kind of therapy to do, what kind of patients to operate upon, and what operation to do.
Alternate routes of fluid therapy, surgical hemostasis, the thoracic outlet syndrome. These are 3 controversial areas in surgery you'll hear discussed this week on Audio Digest Surgery, Volume 18, Number 12, for the week of June 23, 1971. Our consulting surgeons, Ronald K. Tompkins of UCLA, Seymour I. Schwartz of the University of Rochester School of Medicine in Rochester, New York, W. Sterling Edwards of the University of New Mexico School of Medicine in Albuquerque. Moderator for this program, UCLA's Wiley F. Barker, whose voice you'll hear now.
Dr. Tompkins has been interested in the possibility of using alternative routes for the administration of fluid. Ron, I wish you'd take over.
We shouldn't start a discussion of intravenous fluids without paying homage to Rudolf Matas, who was credited with beginning intravenous infusions as a mode of therapy. There's no doubt that this was a great turning point in the care of the surgical patient. However, research into alternate routes stopped very shortly thereafter. I think many of you remember subdermal clysis and proctoclysis as a means of fluid administration. Some areas are still carrying on some of these non-traditional ways of administering fluids. As I mentioned, we became a little bit skeptical of the traditional IV therapy from a number of standpoints. It was common to see patients get overhydrated with water without any saline offered to counteract the saline loss. The discomfort, I think, is obvious from phlebitis not only at the site of the infusion, but many of these patients, because of their immobilization, develop concomitant phlebitis in the saphenous veins. Sepsis and emboli are becoming increasingly common in the literature. It's almost impossible to pick up a journal today without seeing some drastic case report of candida sepsis or embolization of a plastic catheter into the right heart. And this is especially sad when it's done in a patient who really requires these fluids for a very elective operation, such as vagotomy and pyloroplasty for chronic duodenal ulcer or cholecystectomy or some of the other common elective procedures that we do routinely. So because of this, we delved into the history of some other ways to administer fluids. One of the things that was basic to this study was the acceptance of the fact that salt during the operative room period was beneficial. This had been shown, of course, by Shires and by others, that the administration of physiological saline to patients undergoing operation will maintain their sodium balance. It also helps to counteract the extracellular fluid loss that occurs either into the retroperitoneal space or to the wound as edema, or is sequestered in the lumen of the intestine itself with manipulation. So that we accepted this as being the route to follow. We applied animal studies to the study of patients undergoing many elective procedures. As I mentioned, there are many gastric procedures being done, vagotomy and pyloroplasty, as well as hemigastrectomy, the cholecystectomies and common duct explorations. Pancreatic surgery was done, and some of these patients were used. There was a lot of intestinal surgery being done in our particular unit, and so these naturally fell into this group. And we even studied some vascular surgical patients, abdominal aneurysms and bypass procedures. Of the first 8 patients that we studied, they were divided into 2 groups. 4 were treated by peritoneal fluids and 4 by intestinal fluids. The age was quite similar, the sex ratio was similar, and the weight was quite similar. The operative fluid was given at a rate of 25 cc's per kilogram per hour in both groups to try to balance out any differences in volume on our study. In general, the patients had an intravenous started by the anesthesiology department, and they got a maximum of 1,000 cc's on that day. This was usually during the administration of the anesthetic for the operative procedure. They either got 1,000 cc's intraperitoneally or 1,000 to 2,000 cc's in the gastrointestinal tract at the time of surgery. These intestinal fluids were given either through a long nasogastrojejunal tube or more commonly through a gastrojejunal tube. We were routinely using gastrostomies on patients with intra-abdominal surgery, and so it was very simple to modify a gastrostomy tube to have a jejunal limb past the ligament of Treitz to administer these fluids. And post-operatively, the patients were maintained on fluids through one of these 2 tube arrangements. We looked at these patients from the standpoint of their intake and output, obviously. We weighed them twice a day on calibrated scales, and we calculated the sodium balance from the difference of what went in and what came out. In addition, we calculated their extracellular fluid volumes before the operative procedure and at periods after the operative procedure using the 35 sulfur dilution analysis method of Shire's. The installation of peritoneal saline is easily done with equipment you can find in almost any operating room, a sterile funnel and a large pitcher. This is heated to 100 degrees Fahrenheit, and it's Ringer's lactate without sugar. There is some problem with the osmolarity of sugar creating more fluid in the peritoneal cavity for an initial few hours, so that we used it without sugar or dextrose, just simply Ringer's lactate. And the peritoneal sutures were placed. They were all tied except the last one. The funnel tip was inserted into that opening. The assistants hold up on the peritoneal sutures, which are not cut yet. And this fluid, about a liter, is instilled, and the last suture is tied quickly to prevent leakage. And then the closure is done as usual. We developed a double lumen tube with the Davol Corporation, which has a gastric suction lumen and a jejunal feeding limb, which can be placed beyond the ligament of Treitz. And this was the way that we gave the fluids during the operative procedure. Fluid was instilled, and it was interesting to note how a volume of fluid of 1,000 to 2,000 cc's distributes itself along the intestinal tract during an operative procedure with the belly open. It very rapidly propulses down the small bowel and gets into the colon fairly quickly, so that by the time your closure is almost done, it's hard to see any evidence of small bowel dilatation. This goes along with work from British workers who have shown that the small bowel motility is oftentimes enhanced after elective intra-abdominal procedures rather than inhibited, and that most of the atonia we find associated with postoperative ileus is really gastric distension or colon distension, so that it's possible to feed these patients immediately postoperatively through a gastrojejunal tube and have them absorb this type of fluid. The gastric drainage was very low. It never exceeded 300 cc's in a 24-hour period. Perhaps this was because in these particular patients the anastomosis was splinted open by the tube. We don't know. As soon as possible, the patients were begun on oral fluids around 60 cc's an hour. In general, this was done about the 3rd postoperative day. The data on urine output and postoperative weight, the peritoneal group, the intestinal group, the urine output dropped a little bit on the operative day, but was quite dramatically increased and stayed up over the next 3 postoperative days. And generally, by this time, they were taking oral fluids, so we discontinued our studies at this point. The body weight did not increase with this fluid load, indicating that it was being excreted well, and we found no evidence of fluid retention in these patients. Of the 8 patients, there was a 4.3% increase in the preoperative value of the extracellular fluid volume, and this is functioning extracellular fluid, not that sequestered, of course, in edema. We found that the intestinal group dropped back very close to their preoperative level at 24 hours, and this probably reflects a more active transport of Ringer's lactate from the intestine, where there's an active sodium pump. The peritoneal absorption of fluids is a little more passive than this and depends on the concentration in the serum, which is perfusing the peritoneal membrane. Well, I think that probably this study utilized more fluid than we would utilize today, and rather than maintaining extracellular fluid volume, we actually augmented it. What we're shooting for is to find ways to keep it about where it should be, despite the operative trauma. We find these patients are more comfortable. The ones with peritoneal fluids in tend to have less post-operative pain than others, and this is brought to our attention actually by the nurses who were taking care of them. The ones who receive the intestinal fluids, of course they all do, post-operatively seem to have earlier bowel movements, and for some reason or other it may be just the action like a saline cathartic, but they have bowel movements on the first occasionally and mostly on the second post-operative day. The sodium balance picture on these patients that we treated with peritoneal and intestinal fluids, there was an average of 2.6 milliequivalents of sodium per kilogram per hour given to the peritoneal group and 2.8 to the intestinal group. They handled this quite well. Their urinary chloride excretion, the sodium chloride excretion, was quite high, so that it's our theory that these patients dispose of this excess salt very quickly post-operatively. And I should mention that they were given salt intravenously each day. There was no dextrose and water alone given to any of these post-operative patients. There are certain contraindications to use of these extravascular fluids. We don't think that peritoneal fluids should be used with peritonitis. Of course, if you have abdominal drains, and many times we've inadvertently placed a liter of fluid in, forgot about the subcostal drain after a gallbladder, and been amazed to find our shorts were quite saturated by the time we got the abdomen closed, so that this just doesn't make sense, of course. We wonder about liver disease, since most of this goes by way of the portal vein, whether or not patients with portal hypertension should be treated in this method. The intestinal fluid route should not be used, of course, if we have a distal suture line that we want to avoid overloading, and certainly not if there's any element of obstruction in the intestine. We do think that these extravascular fluids have value in selected patients because of the more physiologic absorption of these fluids from the intestine and from the peritoneal cavity. It's virtually impossible to overload a patient with too much fluid by these routes. The extracellular fluid and sodium balance maintenance we've talked about, and this seems to be a plus factor for this. In addition, we have no IV complications because the IV is pulled in the recovery room as soon as the patient's vital signs are stable, and thereafter they get their fluids through the intestinal tube. It allows more complete ambulation. As one of our teachers used to say, these patients with IVs are staked out like a victim of an Apache attack, and they don't get out of bed for 3 or 4 days. These patients with intestinal tubes in can often administer their own fluids down the tube by having it by the bedside. It doesn't have to be warmed, of course, post-operatively. The problems of temperature regulation are not so great. And they don't have to even be sterile to go in the intestinal tube, so that the patient can sit there and give himself fluids 3 or 4 times a day and participate actively in his own care. In general, the patients have seemed to us to have more of a sense of well-being than those who were treated by more traditional methods.
I just returned from a meeting in Washington of the American College of Surgeons Committee on Wound Infection, Postgraduate Infection. And there was a great deal of emphasis at that session placed on the continuing increasing reports of complications from prolonged intravenous therapy. I'm sure that this may not supplement totally all of the intravenous therapy, but it certainly is challenging after you spend a couple of days listening to all the problems with sepsis that people get into from prolonged venous therapy. We're going on to another area, one of the problems that all of us face, surgical hemostasis. I turn the session over to Dr. Schwartz.
Normal hemostasis, by definition, represents the cessation of bleeding from a disrupted vessel. Now, although blood coagulation is frequently equated with hemostasis, it is not always the central or even the most important factor. For example, a patient with congenital afibrinogenemia, whose blood is totally incoagulable in the laboratory, may have only a minor defect and evidence no increased bleeding during a major surgical procedure, since in this setting, the platelets are able to function in a near normal fashion with very minute amounts of fibrinogen on the surface. Let us consider the pertinent question, the evaluation of the surgical patient as a potential hemostatic risk. Now, the history is, of course, important, and one should question the extent of bleeding with circumcision, eruption of teeth, following dental extraction, tonsillectomy, and menstrual bleeding. It is extremely unusual for a patient with a marked hemostatic defect to go through these events without significant bleeding. However, and this is a pitfall, some hemophilic patients with no factor VIII at that point in time have been circumcised without inordinate bleeding due to the transplacental passage of anti-hemophilic factor early in the stage of life. Also to be emphasized in taking the history is that isolated GI bleeding related to a hemostatic defect is extremely rare. These patients bleed from more than one port. Similarly, isolated hematuria, isolated hemoptysis is rarely a factor in which one has to indict a hemostatic defect. The drug history is extremely pertinent. Special emphasis should be placed on aspirin, butazolidine, and other drugs, and these patients should have a close family history since so many of our hemostatic defects are familial in nature. Certain findings on physical examinations routinely should be looked for in order to give clues of hemostatic problems. These include ecchymosis and petechiae to suggest platelet deficiencies, and one of the easiest tests in evaluating our patients is to regard the stick of the needle in which somebody has taken the admission blood sample to note whether there is a marked ecchymotic spot, and this might suggest some abnormality. The recent venipuncture site is one of the most pertinent findings on physical examination. Spider angiomata, ascites, etc., hepatomegaly and splenomegaly suggest liver disease with the abnormality in the coagulation mechanism. The lesions of hereditary telangiectasia, as you know, are searched for in the perioral, perianal regions, and finally, one regards the lymph nodes in order to detect abnormalities in the reticuloendothelial system. Now, the question has been raised, is there a laboratory test to routinely detect hemostatic defects? An ideal test has yet to be described. The most productive laboratory evaluation, interestingly enough, for the surgical patient is a simple evaluation of the platelets. Since thrombocytopenia is without question the most common abnormality resulting in failure of hemostasis in the surgical patient. The bleeding test, the time-honored whole blood clotting time, and the clot retraction time are not recommended for a reliable screening. They really afford little. The quick one-stage prothrombin time is simple, and when combined with the partial thromboplastin time, the sensitivity of these two tests is usually sufficient such that abnormalities liable to result in disturbing bleeding for the surgeon are not likely to be missed. For screening with patients with potential problems of fibrinolysis, such as patients with metastatic prostatic carcinoma, pancreatic disease, then one should perform either a dilute whole blood clot lysis time or a U-clot lysis time. Now, the patient who is suspected, this is the routine evaluation, but the patient who is suspected of having a hemostatic dysfunction requires a more comprehensive history with more particular concern with the drug history and a familial history. If there is any possibility of thrombocytopenia based on the simple smear, then the best test to perform is a platelet count. As far as the coagulation tests are concerned, if a defect is suspected, then one should certainly carry out the combination of the quick one-stage prothrombin test and the partial thromboplastin time. After that, if an abnormality is discerned, then one has the option of doing as the British do, of performing mixing and matching studies, or as we do more often in this country, specific assays for each of these factors are certainly available. We come to the more pertinent problem, that of the patient who bleeds excessively during or shortly following a surgical procedure. This certainly represents an emergency. The bleeding in these patients may be due to ineffective hemostasis. It may be due to blood transfusion incompatibility. It may be due to the unusual circumstance of an unsuspected hemostatic defect. It may be due to diffuse sepsis, the analog of endotoxic shock. It may be due to fibrinolysis or defibrillation. Evaluation of these patients who bleed inordinately during or shortly after the operative procedure should include first a smear of the blood, a very simple test to determine the number of platelets, since the most common cause of bleeding, hemostatic defect bleeding in a surgical patient, is thrombocytopenia. If indicated, the actual platelet count should be performed, then one can rapidly perform a quick test and a PTT and thrombin clotting time. Now, virtually every patient who receives 10 units of our ordinary bank blood within a 24-hour period has measurable thrombocytopenia. But this is usually not sufficient to result in hemostatic failure. If about 15 units or more, however, are transfused within a 24-hour period, then the extent of thrombocytopenia becomes more significant. And the therapeutic approach in these patients, of course, consists of providing them with fresh platelets. One of the axioms for prophylaxis of this thrombocytopenia would be that following the transfusion of 10 units of bank blood, at least equal volumes of fresh and bank blood should be used as subsequent replacement. Now, continued bleeding, as is known, is not uncommonly associated with prolonged extracorporeal circulation. In this case, many factors have been implicated that really have not been precisely defined, but the most common is that, probably, of the introduction of heparin into the circulation and inadequate protamine neutralization. Other abnormalities attributable to extracorporeal circulation are defibrillation, fibrinolysis. The appearance of pathologic fibrinolysis during surgery is in fact quite uncommon, but it can occur in patients particularly who have marked shock and in patients who are being operated on for pancreatic disease, prostatic disease, and carcinoma of the lung. The use of the thrombin time to detect a reduction in circulating fibrinogen and the euglobulin or dilute blood clot lysis time to detect abnormal fibrinolysis is pertinent, but really only in these suspect cases. What I'd like to do now is briefly go through some clinically significant hemostatic defects, beginning with the classical factor VIII deficiency or hemophilia. This is a disease of the male, as you know, occurring in 1 in 25,000 of our population, really quite common, and it is inherited as a sex-linked recessive. The severity of the manifestations in this disease is related simply to the deficiency of factor VIII, the antihemophilic factor. When concentrations of factor VIII are in the range of 25% of normal, the patient does not have spontaneous bleeding, but may bleed with the trauma of surgery or other types of trauma. When the concentration approaches 0, then spontaneous bleeding occurs. The bleeding in these patients is usually first noted in childhood when the child begins to walk and they develop hemarthrosis. Surgically, we should consider the differential diagnosis of the acute abdomen in which the teenager presents with a symptom complex suggesting appendicitis, a known hemophiliac. You should stay out of these patients because the bleeding is usually related to intramural hematoma, which can be well defined by the typical X-ray stack of coin appearance, the imprints of blood on the lumen of the barium within the bowel. Now, the diagnosis is made by specific assay of a hormone of the antihemophilic factor and noticing a reduction. The treatment requires merely the raising of the factor VIII level to levels approaching 30%. I underscore that so that one does not attempt to treat to 100%. This is not needed and can run into a great deal of difficulty. Now, following the administration of a given dose, the time sequence is important to consider. Using the cryoprecipitate, we first get the initial rapid diffusion slope, steep slope, and then we get another rapid slope related to degradation. 24 hours after the administration of factor VIII, no more than 8% remains in the blood, an inadequate amount. A hemophilic patient can readily be prepared for surgery with the concentrates available. You know the play that was recently presented in the newspapers of a patient who underwent valvular replacement with hemophilic. Unfortunately, the patient eventually died. But the point to be emphasized is that this factor disappears very rapidly. And so the concentrate should be continued daily as an administrative drug for at least 8 days after surgery and should be reinstituted for any minor event, including suture removal, because patients have been known to bleed inordinately, suture removal on the 14th day if they have not been protected with AHG. The next disease to consider is von Willebrand's disease, which is also known as pseudohemophilia. This certainly occurs as commonly as true hemophilia, and perhaps more commonly, now that we're getting better assays for factor VIII. This disease is transmitted as an autosomally dominant trait, and accordingly it appears in consecutive generations. Males and females are equally involved. It is characterized first by a diminution in factor VIII, but more important, the level of factor VIII is variable. As we study it at several occasions, we get different levels of factor VIII, unlike the hemophiliac, the classic hemophiliac, who has a persistently low factor VIII. There is no variability in the hemophiliac, whereas the patient with von Willebrand's disease may go from 20 down to 10, up to 30 again. Now, the manifestations are mild with this disease, frequently overlooked until, unfortunately, the patient undergoes surgery and then they become apparent. Severe bleeding can certainly occur with minor surgical procedures. The diagnosis is established by noting the variation in the factor VIII level in a patient who has had a past history of some bleeding, prolonged bleeding time, and the test with a glass bead column of detecting abnormal platelet adhesiveness. The treatment is simple in these patients. It consists of transfusion of modest amounts of bank blood or plasma, since these factors actually stimulate within 4 to 6 hours the factor VIII level. In other words, a small injection of plasma, a small transfusion, initiates the synthesis of factor VIII, and the patients are more readily treated than the patients with hemophilia. Factor IX deficiency, or Christmas disease, is clinically indistinguishable from factor VIII deficiency. The incidence is less common, it's 1 in 100,000, and since factor IX is dependent upon vitamin K for synthesis, it may occur with vitamin K deficiency in hepatic disease. The manifestations are the same as hemophilia. The diagnosis is made on specific assay, and the treatment consists of bank blood or serum. Unlike factor VIII, however, unfortunately, after this initial diffusion slope, the degradation slope is extremely slow, and therefore one does not require repetitive administration of therapeutic plasma. Now, I'm going to skip over the rare factors, factor deficiency, that is 11, 5, 7, 10, 2, and prothrombin, and now concentrate on something with which we'll all be concerned, namely abnormalities in the fibrinogen system.
And Doctor, you can hear Seymour Schwartz discussing the diagnosis and treatment of congenital afibrinogenemia and acquired hypofibrinogenemia and several other hemostatic disorders by just flipping over the cassette or 2 reels on your tape recorder. Side B, Audio Digest Surgery, Volume 18, Number 12, continues a program detailing 3 controversies in surgery. Now, continuing his discussion on surgical hemostasis, Dr. Ronald Tompkins turns to abnormalities in the fibrinogen system.
Congenital afibrinogenemia has been recognized for nearly 50 years and is transmitted as an autosomal recessive gene. Babies have bled markedly following section of the umbilical cord. Patients may present with marked bleeding following lacerations and with purpura, epistaxis. And the diagnosis is established in these patients with congenital afibrinogenemia, whose parents, by the way, are normal, by the thrombin test. And then one measures the fibrinogen level and notes that it is usually assayed at less than 5 milligrams per 100 ml, in contradistinction to the normal, which is greater than 100 milligrams per 100 ml. Treatment is, for the patient requiring surgery, the known congenital afibrinogenemic patient requiring surgery, is really quite simple. It can be accomplished with plasma, but it is preferably achieved with the use of the now available concentrates, giving 1 gram of fibrinogen for every 10 kg of body weight as a loading dose, followed by 1/5 of this dose daily. Might emphasize that the treatment of congenital afibrinogenemia on an elective basis is associated with a substantial risk of hepatitis associated with both forms of therapy, plasma or fibrinogen, in view of the amounts given. Now, the largest group of patients with fibrinogen-related problems of surgical concern are not the congenital afibrinogenemics, but the acquired hypofibrinogenemia category. This is rarely an isolated event, and it is usually associated with deficiencies in factors 5 and factor 8. Most of these patients suffer from intravascular coagulation, known as a defibrillation syndrome or a consumptive coagulopathy. The diseases which are prone to develop the syndrome are transfusion reaction, carcinomatosis, lymphoma, sepsis, snakebite, and cardiopulmonary bypass. The diagnostic findings for the acquired hypofibrinogenemia include a demonstration of a reduced fibrinogen level, and the plasma of these patients, interestingly enough, contains an increased amount of cryofibrinogen which can be detected. The treatment of choice for these patients who are bleeding massively from the defibrillation syndrome is heparinization. Heparinization and the level of anticoagulant level in a patient who is massively bleeding seems almost heretical, but it is dramatic treatment and it will prevent the consumption coagulopathy and stop the bleeding in these patients. One does not give fibrinogen to these patients. Since they have a consumptive coagulopathy, it will only augment the consumptive process and sort of irritate the situation. IV heparin will definitely reverse the bleeding, and the effect of heparin can be defined in these patients. These patients with the acquired hypofibrinogenemia have a reduction in their platelet counts, and this is one of the other methods of determining and differentiating this from fibrinolysis. They have thrombocytopenia, which can be detected on a spear, and shortly after the administration of IV heparin, one notes a rise in their platelet count, and so you can see the effect of your therapy quite rapidly. Now, the acquired hypofibrinogenemic state can also be due to fibrinolysis. Unfortunately, this is a term which is used too frequently in the surgical literature. These are patients who have either a decrease of the plasminogen activator or an inability to clear the activator from the serum. It may occur with prostatic carcinoma, shock, sepsis, carcinomatosis, etc. Now, the bleeding that occurs in prostatic surgery is a localized fibrinolysis, and we'll all admit to that enzyme defect. However, the usual bleeding that we see in the surgical patient is a defibrillation bleeding and not a fibrinolytic bleeding. The diagnosis can be established in these patients by noting a reduced fibrinogen, reduced factor 5 and 8. These patients, however, do not have thrombocytopenia, unlike the consumptive coagulopathies. Assays in these patients are not practical. They take too long. Now, it's this group of patients in which there was an enthusiasm for the use of epsilon aminocaproic acid, and I think I've reached the personal posture with this drug of saying that none of my house officers can use it in a bleeding surgical patient unless they call me first, because it has done more damage than it has done good. And therefore, I emphasize the importance of treatment with bleeding in acquired hypofibrinogenemia is treating of the underlying disorder, the shock, the sepsis, waiting. EACA and tracelol should be held back as long as possible. Restraint is most important. As I mentioned twice earlier, thrombocytopenia is the most common abnormality of hemostasis resulting in bleeding in a surgical patient. This diagnosis is readily established just by regarding the smear. If there's any question, again, one can perform a platelet count. Now, if the platelet count is greater than 60,000, the chance of indicting the thrombocytopenia as bleeding is really quite minimal. Now, management of the patient who is thrombocytopenic for elective surgery, let us say you have a patient who is known to be thrombocytopenic and you're considering elective surgery, can follow one of 4 courses. If the platelet count is really 70,000 or greater, you really don't need any concern and no treatment is required. If the platelet count is in the range of 50,000 or so, then there is a case for using steroids, which seems to decrease the bleeding phenomena without altering the platelet count itself. Now, in some patients who do not respond to steroids, who are going to undergo a major procedure — I recently had one who had to have an abdominoperitoneal for rectal carcinoma — then it is justified to perform an initial splenectomy in order to raise the platelet count before taking on the more Herculean task of, let us say, an abdominoperitoneal. We do have available for patients who require emergency surgery either fresh platelet-rich plasma or platelet concentrates, or fresh blood itself, which will provide platelets. Now, in the face of a spleen which is actively destroying platelets, let us say a patient with known idiothrombocytopenic purpura who has to undergo emergency surgery, it is pointless to use platelets before the spleen is removed, because the platelets are immediately destroyed and really provide very little. I think it's imperative in any consideration of bleeding during surgical procedures to consider those group of patients with myeloproliferative disorders. This is a spectrum of disease now, beginning at polycythemia vera, progressing to the now what was known as myeloid metaplasia, and usually terminating in a chronic myelogenous leukemia. Surgery in this group of patients is fraught with extreme danger. There is an increased morbidity following operation, there is increased bleeding during operation, there is increased postoperative hematomas and postoperative infections. In our group of splenectomy, we have recently reported of 200 splenectomies. The group that had the worst results as far as postoperative mortality and morbidity were those patients with myeloid metaplasia or myeloproliferative disease. Presented with a patient known to have myeloproliferative disorder who requires elective surgery, then it is imperative to treat the patient with either busulfan or chlorambucil to the extent that the erythremic state is reduced and the platelet count is reduced to less than 400,000, hematocrit less than 48. Because it has been shown that the bleeding phenomena in these patients can be related to the erythremic and the thrombocytotic state. Now, we always see patients, or occasionally see patients rather, who are known to have polycythemia vera, who are erythremic, who require an emergency procedure. In those patients, it is imperative to perform a phlebotomy before the surgical procedure so their hematocrit is reduced to about the 45 range and their platelet count is also reduced. Actually, if at all possible, elective surgery should be avoided in the patient with myeloproliferative disease, and the surgeon must have extreme meticulous care in operating on the patients in view of the postoperative bleeding. Now, there are a variety of other disorders associated with increased bleeding, either intraoperatively or postoperatively. There are lymphoma, carcinoma, cirrhosis, and a variety of drugs have been indicted by influencing the hemostatic process. They include the alkylating agents used by our oncology friends. Chloramphenicol has been indicted. Salicylates, either taken orally or taken by the vascular route, can be indicted. Phenylbutazone, and of course the drugs with which we're most concerned, the anticoagulants. Surgical intervention may prove necessary in a patient receiving anticoagulant therapy. How do we consider this problem? Now, when the clotting time is less than 25 minutes in a heparinized patient, or when the prothrombin time is greater than 20% in a patient who has been coumadinized, really nothing is required because these patients do not bleed inordinately. However, if these times are prolonged, then one can reverse the heparinization rapidly, of course, with protamine sulfate in the known doses, whereas hypoprothrombemia can be reversed in patients with good liver disease in about 2 to 4 hours with vitamin K1 oxide. Now, recently, we had an interesting experience of operating on a patient with a prothrombin on 2 repeated occasions of 12% of normal. The patient had a ruptured aortic aneurysm, retroperitoneal rupture. We performed the resection and insertion of the graft, and really there was no inordinate bleeding and no inordinate postoperative bleeding, and the postoperative prothrombin time was 15%.
There's been apparently some confusion about this thoracic outlet syndrome. It could be also defined as the shoulder girdle syndrome, or the shoulder girdle neurovascular compression syndrome, or almost any pattern of those adjectives you want to throw together. And Dr. Edwards is going to solve all of those problems for us.
The thoracic outlet problems all, as you know, arise in the triangle between the clavicle and the first rib, in the costoclavicular space. This space is bounded superiorly by the clavicle and inferiorly by the first rib and laterally by the scalenus medius muscle. The compartment, the costoclavicular compartment, is divided actually into two spaces by the scalenus anticus muscle, which divides it into a space behind the scalenus anticus muscle. We have the subclavian artery and the brachial plexus, and anterior to the scalenus muscle, the jugular vein. This syndrome that we are speaking of then is a syndrome of pain in the arm, the shoulder, the forearm, and sometimes around the chest wall itself. This pain almost always has an ulnar distribution as part of it. About 98% of the patients who have proven costoclavicular syndromes and thoracic outlet syndromes, there is a degree of ulnar distribution and ulnar paresthesias with this. So nerve compression is one of the major problems. And in the past, we've had no real way to diagnose the definitive nerve involvement. We've gone on indirect evidence, such as vascular compression. The trouble is that only about 30% of the patients have any vascular symptoms or even signs. The vascular component takes two forms. One, when the subclavian artery is compressed, there may be loss of pulse in various positions. There may be claudication if there has actually been thrombosis of the subclavian artery. And occasionally, actually, patients develop gangrene of the arm and lose this extremity, lose the hand. And this, of course, is a true tragedy. The vein, on the other hand, is less frequently involved, and symptoms of venous compression are those of edema. Now, intermittent edema usually means simply compression of the vein intermittently, but constant edema usually means thrombosis. And I think that the old syndrome we used to call effort thrombosis of the subclavian vein is probably related to a period of compression by this shoulder girdle compression mechanism that leads to stasis with thrombosis and then chronic edema. So we have so many different nerve, artery, and vein symptoms that it's a little hard to make sense out of these things. In recent numbers of cases that have been seen, it's been found that about 90%, 98% of the patients have nerve symptoms, pain and paresthesia. About 25% of the patients have arterial symptoms, that is claudication, coldness, thrombosis of the artery. And only about 10% of patients with shoulder girdle problems have edema of the arm or venous symptoms. Now, the arteriogram has been used by some as a definitive method of diagnosis in the shoulder girdle or thoracic outlet syndromes. Selective injection of dye into the left subclavian artery in a patient with the arm down at the side. The same patient with the arm abducted and extended up causes an obvious compression with a second injection, and this is helpful if it is found, but too often such a lesion is not found when the patient has only nerve compression and not really vascular compression, and it's not necessary, we think, anymore to do this procedure, to do arteriography to make the diagnosis. One of the big problems has been that the diagnosis in the past has been one of exclusion. We simply take a patient who has shoulder and arm pain and try to exclude certain things such as cervical spondylitis, cervical arthritis, superior sulcus tumors of the lung compressing the brachial plexus. And if we can exclude all of these things and the patient still has pain, and even if he has no vascular component to this problem, operation would be performed in hopes that he would be relieved of his pain. And this has been the status until quite recently. Of course, if we found a bony abnormality, this would be a great help, such as a cervical rib on X-ray, or an old fracture of the clavicle, which might compress the structures in this compartment. It would be more likely that the diagnosis was correct. The vascular compression positions, the postures that have been used that we all have tried so much. Adson's test of rotating the neck to the opposite side, elevating the chin and having the patient take a deep breath while we palpate the radial pulse, and the positive sign being the diminution of the radial pulse. This is most frequently positive when the patient has a cervical rib, but it may not be positive in some of the other anatomical variations of this syndrome. The military position has been used quite often in diagnosis. That is, having the patient pull his shoulders backwards and downwards as though he were carrying a heavy pack with obliteration of the radial pulse. When he does this, this is called the military or the Costoclavicular Test. And this is more often positive in a patient who's had a fractured clavicle with a big callus formation, which is compressing the structures in this space. The other tests, hyperabduction, hyperextension, I think that almost any one of us can find some position around the head where you can obliterate your pulse. If you don't believe it, try it sometime. So that these are very indefinite tests. If they are present, they may mean something, but you can obliterate the pulse in practically everyone in some position of the hand and arm around the shoulder girdle. It's been found, though, that patients with a true thoracic outlet syndrome do have compression and obliteration or diminution of the pulse in one of these positions, usually either the Adson's or the military position. So the absence of a pulse diminution in one of these positions should make one indeed a little suspicious of the diagnosis. I think the most useful test that's been developed is a test that's been suggested and popularized recently by Dr. Urschel and Paulson and the group down in Dallas, using the ulnar nerve conduction velocity as a method of diagnosis of the thoracic outlet syndrome. Now, this is done using an electromyograph and tests the stimulation or the reaction potentials in the hypothenar space muscles. These muscles are tested for their reaction, and stimulation is applied in the forearm and in the upper arm and in the supraclavicular fossa. The average conduction time from the forearm to the hypothenar space is 59 meters per second. In the upper arm, the average conduction time is 55 meters per second. And in the supraclavicular fossa, the conduction time is 72 meters per second. This is across the thoracic outlet. This test is a very simple test. If one has the equipment and someone that's knowledgeable or experienced with it, is helpful in several ways. One, it can separate the patients who have other nerve compression syndromes, such as the carpal tunnel syndrome. If one has a conduction velocity across the wrist, this would certainly be suggestive and diagnostic of carpal tunnel syndrome. If the patient had a reduced velocity across the elbow, this would strongly suggest the ulnar nerve compression entrapment syndrome rather than shoulder girdle syndrome. If the conduction velocity across the thoracic outlet were shortened, this would make the most likely point of trouble in the thoracic outlet itself. It's been found this 72 meters per second is the average time velocity that has been found in normal individuals. And in Dr. Urschel's experience, the average conduction time in those patients with thoracic outlet syndrome has been less than 60 meters per second. Some have a little greater than 60 meters per second, but most of the patients with true thoracic outlet syndrome have conduction velocities less than 60 meters per second. The therapy for this now is beginning to get a little bit more clear also. First of all, let's say just a word about conservative therapy. If the patient has mild symptoms and if the ulnar nerve conduction velocity is between 60 and 70 meters per second, the group in Dallas have found that conservative therapy has been tremendously helpful. in the way of improving their symptoms. This conservative therapy consists of shoulder-girdle muscle exercises to strengthen the muscles and emphasizing better posture. The age of onset of almost all of these symptoms is in the 30s and 40s. The reason for this, we think, is because this is the time when the shoulder-girdle muscles began to become less active and strong and to atrophy, and the shoulders begin to sag. And even with perfectly normal anatomy, with no bony abnormalities, the space between the first rib and the clavicle becomes narrow in middle age and emphasizes any narrowing and compression that the patient may have been born with. So shoulder girdle exercises and postural improvement do a lot, especially in patients who have only mild nerve compression and ulnar nerve conduction velocities of between 60 and 70. The group in Dallas again have stated that if the ulnar nerve conduction velocity is shorter than 60 meters per second, most of these patients will not respond very well to exercise and posture alone and will require surgery. Surgery has, in the past, as you know, taken several forms. Resection of the scalenus muscle, scalenotomy, was the popular thing a few years ago, and this was pretty well given up because the recurrence rate of pain has been very high, and quite often there was no initial relief of pain even. Another approach has been the removal of the clavicle, feeling that this would remove the top part of the compression. The trouble is that there are muscular bands, fibrous bands, and the scalenus muscle itself, scalenus anticus muscle, that would not be affected in its compression by removal of the clavicle alone. So this was not very effective. In the past, we've tried to define exactly what structure was compressing the brachial plexus and the subclavian artery, and this has been very difficult, and try to design an operation to exactly remove whatever was compressing the structure has not been very successful. I think it was probably first pointed out by Dr. Claggett in the Mayo Clinic that the root of all of the compressions is the first rib. Dr. Claggett, having had tremendous experience with thoracoplasties for tuberculosis, approached this as a thoracic surgeon would and took out the first rib in a number of these patients through a posterior approach by resecting the muscle and swinging the scapula up and approaching it exactly as you would a thoracoplasty. This does the trick all right, but it's probably an unnecessarily extensive operation. One can do the same thing, actually, a little less effectively through an anterior approach, either above the clavicle or below the clavicle. One can take the first rib out, but it requires quite a lot of retraction on the brachial plexus to get around the brachial plexus to take this first rib out. And sometimes neuritis develops from this retraction. But this still is a good operation, I think, and if there is a problem with the subclavian artery. In some cases, you may see there will be a small poststenotic dilatation or aneurysm of the subclavian artery, and this may need treatment such as a replacement graft. Sometimes there's thrombosis of the subclavian artery, and this may need to be dealt with at the time of surgery. So that if arterial surgery is required, the anterior approach is a good one. The most generally useful approach, however, is the one that has been recently popularized by Roos in Denver, and that is the transaxillary approach, making a little small incision in the hairline of the axilla with the patient with his arm extended and often held by an assistant or held to an anesthesia bar. This approach does not cut across any muscles. It is a little difficult because exposure is more difficult here. There is quite a long way from the skin incision up to the first rib, but with some experience this becomes easier, and with good retraction. The first rib is stripped of its periosteum, and in stripping it, one then would remove the scalenus anticus and swing it up. There's little danger of damage to the vessels. Occasionally one may get into the pleura, but with care this is not a real hazard. The scalenus anterior the scalenus medius are both removed with the periosteum from the first rib. Then the entire first rib is removed. And to close this incision, really nothing is needed but a subcutaneous and skin stitch. No muscles need be closed since none have been cut. And the patient usually can go home from the hospital in 2 or 3 days because it's a relatively painless postoperative period. How effective is this removal of the first rib as far as the syndrome is concerned? If we have made the right diagnosis, that is, if the patient has the classical type of pain distribution in the shoulder and arm and the ulnar distribution of paresthesias, if there is pulse obliteration in at least one of these positions, if the ulnar nerve conduction velocity is below 60 meters per second, if these 3 criteria are met, about 95% of the patients will be essentially cured of their difficulties since the diagnosis was almost certainly correct. The ones that cause trouble are the patients who have an atypical pain distribution, the patients who have some whiplash type of cervical injury with pain around the shoulder, the patients who may or may not have pulse obliteration in one of these positions, and especially the patients who have no real shortening of their ulnar nerve conduction velocity. These patients usually have poorer results and not much help from the operation. So I think with a better understanding of the clinical history of the patients, the typical classical type of history that we might expect, we do not any longer really need to try to precisely define what structure it is that's causing the compression. We simply need to make sure that this is a compression in this area, and with the more broad surgical treatment of taking out the first rib rather than trying to cut the structure of the muscle or band, the surgical therapy of this lesion should be a lot more precise in the future, and I think that ulnar nerve conduction velocities, as popularized by the Dallas group, is going to be a big help to us.
And this concludes this 12th edition of Audio Digest Surgery for 1971, produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Our thanks to all participants for their cooperation in recording and disseminating this material. And a reminder to you, Doctor, that your next issue will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over the 52-week calendar.